Everybody, or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and managing editor of BBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Milliman MedInsight. And this one is titled Thriving Under Team in Building Towards CMS's 2030 Value-Based Care Goal. And very excited to hear from our speakers, who I will introduce momentarily. A couple items of note before we get started. Today is a traditional webinar format, and so everyone has joined today in listen-only mode. So we can't see you or hear you. However, we do want to hear from you, and we're going to have time for some Q&A towards the end. And so if you have a question for either of our speakers at any point during the presentation, go ahead and drop your question into your control module. There's a place specifically for questions. And so you can just drop it in there. We have a big audience today and a lot to cover. So we're going to get to as much as we can, or many of those questions as we can. If we don't get to yours though, don't worry. Someone will make sure to reach out and make sure we get your question answered afterwards via email. Also, the session today is being recorded. So what's going to happen is when we conclude, maybe about an hour or so afterwards, you will receive an email, and that email, which is the same email you registered with, will have a link to the recording as well as to the slides that you can download. You're going to want to do that because there's a lot of great information on there that you can review and share with colleagues and friends, and we hope that you do. Finally, without further ado, let's go ahead and introduce our speakers today. With us, we have Miss Pamela Pellizzari, and Pamela is a principal at Milliman. And prior to joining Milliman, she worked as a senior technical advisor and model lead at the Center for Medicare and Medicaid Innovation, where she designed and implemented episode-based models in the Medicare program. At Milliman, she now works with payers and providers working to succeed under models such as TEAM. And Pamela, if I could get you to advance one slide forward. And we can see, there you guys are. All right, and then also with us, we have Miss Alyssa Panini, and she is a healthcare product director at Milliman with responsibility for Milliman's bundled payment reporting interfaces. And in this role, she works to transform claims data into actionable insights to support clinical quality and financial teams at hospitals and health systems participating in episode-based models. So they definitely know what they're talking about today, and look forward to hearing from them both. And at this point, I'm going to turn it over to you two. So welcome to you both.
Yeah, thank you so much for having us. We're happy to be here. So to start off, I'll just give you an idea of where we're going today. So you've met us now. We're going to start with some early observations. So what is the team model, and sort of how's it going so far? I guess we're now officially about 3 weeks into the model, right? And we want to have some early observations on what we've seen from CMS and from participants. I think then we'll move to sort of, why is this important right now, right? What are the stakes, and what would be the reasoning for you to get started and get doing something at your hospital if you haven't already? And then we'll move to action planning. How can you really operate successfully under team at your site? So to start off, I think we want to get a sense of the audience and who's here today. So I'm going to advance the slide to our first polling question. So we're going to ask the audience here, which teams do you primarily represent or support? And we have several options here. So I think Garrett is pushing a poll to all of you, and we're hoping you can let us know, are you more aligned with clinicians and care teams, with quality and patient safety, with finance, actuarial, and contracting, with population health, payers, and value-based care, or something else?
All right, you should see this up on your screen here. So, and we got the results are kind of rolling in, so we'll give it another little bit for folks to respond. And again, which teams do you primarily represent or support? And by the way, this is anonymous. We're going to have a couple of these polls today, and they're anonymous, so feel free to participate. And we're going to show the results here as soon as the results come in, and that way you can kind of see where you stack among your colleagues. So looks like people are still answering. So I'll give it another maybe 10 seconds, and then we'll close it down. I'm going to close this one down in 5, 4, 3, 2, and 1. Okay, Pamela, are you able to see those results on your screen? And if you wouldn't mind reading out the percentages for those who might be calling in.
Yeah, absolutely. So I can see the results. It looks like we have about a quarter of you indicated you support clinicians and care teams. The biggest response was population health, payers, and value-based care. I'm looking at about 46% if we're being specific. And then another 13% said you support finance, actuarial, and contracting, and a lower number, between 5 and 10% for quality and patient safety or other. So that's in alignment with what we were sort of expecting, to see a lot of engagement in the population health arenas. And also, since this model is live, clinicians and care teams, I think we have something to offer all of you. So that was quite useful. And we're going to follow that up with another polling question, right, to help us understand what your needs and interests are. So just, we are only about, I think I said 3 weeks into this model, but the next polling question is really, how prepared do you feel to support team at your hospital or the hospitals you support in 2026?
Okay, just like before, you should see this on your screen. And if you're just joining us, again, this is anonymous, and we're going to have one more later on in the presentation here to play along at home. How prepared do you feel to support team at your hospital in 2026? It's very prepared, somewhat prepared, not prepared, or not applicable. I'm not a team participant. We've got a lot of folks who are just here to learn today, and which is great. I'm glad to have you. Okay. So it looks like most of the results have come in. So I'm going to close it down in about 10 seconds here. All right, I'm going to close it in 5, 4, 3, 2, and 1. Okay, Pamela.
Yeah, I can see the results. So I think, good participation in this poll. I'm seeing 14% of you feel very prepared, so congratulations to you. 44% feel somewhat prepared, so you have some areas you feel strong, but there are some you need improvement in. 10% are not prepared, and you feel that you have significant work that you need to do. And then 32% said sort of not applicable. You're not currently a team participant. So maybe you're a vendor who works with them. Maybe you're just interested, you're a payer, you want to learn a little bit more. So again, thank you for participating. I think that's helpful for us as we frame our comments. And now we'll jump into sort of what our goal is for today. So this is about team, this webinar, the team model, but it's not just about team. I think it's helpful to think of team as, a mandatory training ground, but a training ground nonetheless in some ways. So you might be able to develop tools and processes that can be applied elsewhere in your organization now or in the future. As we think about team, it is live, right? It is currently happening. So it's definitely time to get up and running if you haven't yet, if you weren't one of those people who said you hit the ground running. I think we'll talk about how you can accelerate your performance over the next, weeks and months. So first we'll do a quick refresh. We're going to keep this quick because I think a lot of you know a lot about this model already. So team, the transforming episode accountability model, is a 5-year mandatory model. It impacts acute care hospitals in 188 CBSAs, so 188 geographic regions in the country, and it includes 5 acute episodes that are triggered by both inpatient and outpatient procedures, and those episodes include surgery and post-acute care. In real time, payments are not changed, so Medicare fee-for-service payments will flow as they usually do, and there will be a retrospective reconciliation process that happens after the end of each performance year. Target prices that are used in that retrospective reconciliation process are set based on risk-adjusted and trended regional historical spending, and it's adjusted for quality performance. So all of this is retrospectively occurring, but you will be measured against your performance, including your performance right now today. So those 5 key episode categories we're talking about cross different clinical areas. They include lower extremity joint replacement, surgical hip and femur fracture treatment, spinal fusion, coronary artery bypass graft, and major bowel procedures. The episodes generally trigger based on an inpatient MSDRG. So you have patient eligibility criteria, obviously. This is only Medicare fee-for-service patients, and it only includes a subset of them. They have to meet a variety of criteria. If they have one of the key MSDRGs that are part of the model, they would start an episode. In the case of the lower extremity joint replacement and also the spinal fusion episodes, there are some HCPCS outpatient triggers as well. So for patients who have an outpatient procedure, they are also eligible to start an episode. Episodes include the initiating surgery as well as most post-acute care. For, they would say 30 days. They do count the day of discharge or the day of the outpatient procedure as the first of those 30 days, which is why we're saying 29 days. There are some limited high-cost exclusions for certain categories of spending that are unrelated to the anchor procedure, but most care is included in the model. So CMS has taken sort of a broad approach, and that's similar to what we've seen in former models, that they are interpreting a lot of what happens in that 30 days to be related to the trigger in some way. So that's the overview, right? That's what we're talking about here. TEAM is only a Medicare fee-for-service model, but we will talk a little bit more about how it might be applicable to some other things you're doing. So what patterns have we seen as CMS launched TEAM, which started on 1/1 of 2026? So first, we would say we are seeing them use a lot of legacy systems. If you have participated in other models, whether those are ACO models or even more closely related if those are episode-based models, such as CJR or BPCI Advanced, there are a lot of similarities in what we're seeing. CMS is using a lot of the same systems to manage claims distribution, to collect information from participants and things like that. And while we're seeing some efficiencies, there's a bright side to that. CMS didn't have to reinvent the wheel. We're also seeing many of the same issues you may have seen in the past, right? So maybe your uploads to their online system aren't working correctly, or there are some challenges with their feedback loops. Things are getting lost in their ticketing system, things like that. So there are highs and lows to this, but I guess what we would see is, or what I'd say on the high level, is CMS hasn't really reinvented the wheel here, right? They are depending on things they've developed in the past. The second is that there's a lack of key details in some cases. So communication from CMS, as well as responses to participant questions, have not necessarily been consistent. We see some questions that are answered really quickly. Sometimes one might argue too quickly, right? And CMS is going back and saying, well, that's not exactly what we meant. Some questions are going unanswered. I think in some cases, this is creating frustration or sort of anxiety related to, are you really going to be able to meet the deadline if you can't get their system to work, right, the way that you were hoping it would work? I was a former CMS employee. There are certainly some deadlines that are really, really important, making sure that you've selected your track or things like that. But I do think that CMS is trying to take in the information they need. So, doing your best, it will go far here. So, imagine you're worried you might miss the 12/31 deadline for updating your clinician list because the portal isn't taking your upload. Send an email and say, I'm trying to upload this list, right? I understand people are trying to call CMS. They don't always answer. You don't always know who to call. CMS is aware of these issues. They are working on them. So just making sure you are making it known sort of what problems you're having is quite useful at this point for them to understand the scope of these issues. The third area that we'll talk about is data delays and errors. This is a big issue for us at Milliman. Obviously, we are an actuarial firm, and Milliman MedInsight generates tools based on this data, right? That's a lot of what we're doing with our clients. So the data delays and errors are sort of a big issue for Milliman. We would say, in general, the data we were hoping for to support the model has been slow to arrive, and it's already received multiple rounds of revision. More specifically, I think we've had a couple of sets of data released so far. There was some preliminary data released in the spring of 2025. I would argue that data actually came a little bit faster than I might have expected. I think if CMS hadn't sent that data out so quickly, people wouldn't have been surprised. I wouldn't have been surprised, right? However, that data had some notable errors in it, related to a couple of things. I think maybe most importantly related to the risk adjustment calculations that they did in that data. And so even though you had the data and you had it pretty quickly, it was incomplete, right? Because it doesn't cover as much time as you wanted. It didn't cover the entirety of the time period. And also there were some errors in the risk adjustment, which CMS sort of acknowledged to us when we pointed them out, but didn't actually fix them. They sort of said, we're going to fix those when we send out the next set of data. And then when they sent out the fall, I think they called it fall 2025 baseline data and target pricing data, that data came, I think, a bit slower than we had expected, right? Given the model was set to start on January 1st, we were certainly hoping to have that data more than 2 weeks in advance of that start date. I know a lot of you were as well. There were some errors that we had seen in the spring data that were corrected in that fall 2025 data, but there were others that were not, and we have already had sort of a reissue of that data, as many of you know. CMS, not 2 weeks after sending out the data said, oops, please delete these files and we're going to send you an alternative set. So I think that's something that has, held some participants back, sort of this question of, can you really depend on this data? I think we're going to all have to get used to depending on the data and just being able to identify when there are errors or changes or patterns that are relevant to us. So given all of that, sort of where we currently are with TEAM, there's this fundamental question of like, why should I care, right? Why should I be acting now? Or maybe why should I be paying attention to TEAM at all? And I think it's a reasonable question, right? You are all very busy people. I assume we have a lot going on. So this question of why should I pay attention is a real and important question to consider at your site. So first, I would say, if I were making an argument for why you should at least pay attention to this model, the first would be that TEAM and other episode-based models clearly have some staying power. So CMS has been generating these episode-based models in large scale, I would say, for about 15 years now, right? So this one in particular, TEAM, is mandatory in a large part of the country, right? 188 CBSAs is really a lot of hospitals. Hundreds and hundreds of hospitals are affected by this. TEAM survived 2 full years of rulemaking cycles, so multiple proposed rules and multiple final rules, and 2 presidential administrations, right, including notable pushback from stakeholders, and yet it was finalized, right? Here it is, it's really happening. There is realistically some potential that this model or models like it will expand into other areas if it is successful, and by other areas, that could be other episodes, it could be other geographic areas, depending on how CMS interprets their authority to expand these types of things. But I think first tenet sort of argument is that TEAM does seem to have staying power. The second is that TEAM is going to give you an opportunity to learn in a narrower financial context than ACO models. So for those of you that are in an ACO models, that's a lot of money that you might have at risk, right? Thinking about the total cost of care for that set of beneficiaries. For TEAM, you're addressing specialty care, right? It doesn't put so much at risk. Not that you got to pick this, but the reality is TEAM doesn't put so much at risk, but it does give you the opportunity to test and apply some of the tools you might have for population health and cost management, things like discharge planning or physician compensation and incentive models. And you can actually learn from that as you think about what works and what doesn't in your particular context. The third one is the experience that you can gain from TEAM that might be something you could expand to other lines of business. That might mean simply ACO models, but it might mean other payers, right? Other models. of course, the main reason to care is that CMS sort of says you have to care if you are in this program, right? CMS has made it mandatory, and they are going to hold you financially accountable. And that leads me to sort of the financial mechanism here. So Team offers a glide path to financial risk. So they're going to hold you financially accountable. And on the negative side, they might not be doing that till next year. I know that year one is arguably sort of more of a practice year, right? You might need the practice, but it's worth noting that theoretically you have no downside risk in track one for the first year. But that doesn't mean you shouldn't pay attention, because for many of you, you will be moving to full risk by next year, right? We'll be moving to track 3. Some of you are able to put that off for longer or to lessen the amount of risk that you hold. What are the longer term impacts of this? I think it's the way we think about it. Year one doesn't necessarily include downside risk. So you might not be at risk of losing money this year in Team, but it does drive your ability to accrue savings in future years. So I think 3 things I would focus on as you think about that. One is the target pricing mechanism there at the top, right? So episode target prices are set based on your region, not based on your own performance. I've had multiple people say to me sort of, well, I might as well not start improving this year because that'll drive down my price next year. For the most part, your own performance is quite a small part of overall regional performance, and the region might move on without you, right? So whereas right now you might need to improve a little bit to make it to sort of the regional target that's been set, next year you might need to improve even more, which sort of decreases the likelihood that you'll be able to make that change overnight. The second area would be the quality scoring. So quality scores for this program are complicated, right? There's a composite quality scoring mechanism that takes into account multiple measures. Those measures change a bit over time, but those measures are financially quite impactful, right? And it's very likely that you'll need some time to get motivation, to measure historical performance, and to move forward in ways that will improve your composite quality score and thus your savings potential. The third area to think about is post-acute spending. So post-acute spending patterns, which are one of the clearest savings opportunities in Team for many hospitals, making those changes is going to require alignment of multiple parties to make a real impact on your bottom line. So if you don't have the time or the will to get buy-in across your organization to drive down some of that post-acute spending, you're going to have trouble meeting the regional target prices, particularly as others in your region might be, again, working towards more aggressive goals for post-acute utilization and spending management. And so as you think about Team, this is something that you should really focus on is, do I have the time to actually make the changes I need to make to succeed? So next, I'm going to turn it over to my colleague, Alyssa Panini, and she's going to talk about some key questions for Team participants and how you could answer them. I know some of you here are already familiar with Milliman MedInsight's analytic tools, either directly through working with us or through our collaboration with Premier, which provides wraparound learning collaboratives for Team participants that typically include these analytics. However, I hope you can come away with some action steps anyways, whether you've seen some of this before or whether this is brand new to you. So over to Alyssa.
Thanks, Pamela. Okay, we're going to start with key questions that Team participants should be focusing on. And those are, what is my projected Team episode volume? How significant is that volume and cost in my total book of business? How will I perform against projected Team targets? How do my post-acute care patterns compare to national or regional benchmarks? And do I have the internal support to succeed in care transformation? So we are in the performance period, but we do not have performance data yet because it's only been 3 weeks. We do, however, have the baseline data. So Milliman has developed tools and analytics using that baseline data to help participants answer these questions and gain insight from the historical data. So you currently have access to 3 years of your historical team episodes. So the first main question that you can answer is kind of what your volume is expected to be. How many episodes will you be held accountable for, both in terms of yearly performance periods, so get an idea of how many episodes you can expect to have in 2026 and moving forward, as well as kind of any yearly variation that you would have. We don't expect you to have, concrete number of episodes every single year. There could be some variation that will play into kind of costs, patient case mix, so forth and so on. In addition, you can also see how your episodes are distributed amongst the different service lines. Do you have significant volume in, say, only lower extremity? Do you have volume in all of the episode types? Being able to identify which service lines are going to be impacted is helpful, as well as any trends in or variation in kind of your triggering codes and your episode types. Next, we can review kind of your total expected gains and losses. We can review and see what your historical outcomes would have been to give you a sense of how impactful team will be in the future, and how much action you need to take. So if nothing else changed, are you kind of expected to do well in this program, or do you need to kind of prepare and improve? And within those gains and losses, you can further look into the specific episode types to see which of those episodes are driving those gains and losses. As we've discussed, this program covers multiple service lines. There is some overlap in some of the episode types, but for the most part, they could be completely separate. There's different care patterns. There's different physicians involved. There's different post-acute trends and patterns that will need to be researched to see kind of what needs to change. And it's not necessarily going to be a one-size-fits-all approach. Lastly, it's helpful to understand these gains and losses in relation to your fee-for-service revenue. So nothing changes in the day-to-day. You're still, billing Medicare for these services, but it's helpful to understand kind of how the gains and losses compare to your total revenue and see how impactful the program will be and help you decide what actions you might need to take. Put simply, there might be some losses that you don't really want to make any changes for because it would decrease your fee-for-service revenue too much. Okay, so that was the first kind of set of questions that we think you should be focused on. Moving forward, once you've kind of identified the maybe poor performing episodes, one of the key areas to do further research into is your post-acute spending opportunities. There may be some opportunities in the anchor admission or procedure, but we think based off of what we have seen of the data, more opportunities lie in the post-discharge time period. So for episodes where you are potentially, not doing so well, you can review your utilization of post-acute services. And Milliman has also developed regional and top 10th percentile national benchmarks using the Medicare 100% research data to allow you to see how you compare to the peers in your region as well as nationally for those top performers. And these benchmarks are done at the episode cohort level. So the level that CMS is determining the target prices to give you kind of the most accurate comparison available. And so we have used these benchmarks to kind of see what opportunities are available and then converted any reductions in utilization to estimated savings to see which areas of opportunity are most cost effective. So in this example, there's significant savings opportunities in inpatient rehab facilities, both at the regional level, but significantly at the top 10th percentile level. There's also some opportunities for improvements in skilled nursing facility, both in terms of utilization as well as the average length of stay. And so moving forward, we can dig more into those areas to kind of identify any specific patterns that may be causing these kind of opportunities. Can move forward. So another key aspect to reviewing your post-acute performance is further delving into the providers, specifically for those service types that have significant opportunities. So our previous example had inpatient rehab and skilled nursing facility opportunities. So your claims data has provided claim level information that includes the providers that are handling your patients. And so we can view those both individually and aggregated to show you which downstream providers are contributing to your gains or contributing to your losses. So in terms of skilled nursing facilities, high-performing SNFs can drive savings, whether that be through avoided readmissions, they're handling their patients well, discharging them quickly so they have a lower length of stay, or they can be contributing to your losses by having, higher lengths of stay and or the patients are being readmitted for some reason. So you can delve into your post-acute care providers and identify any potential changes that need to be made, as well as any, partnerships that would be useful to recommend to your patients. Okay, next slide. And finally, one of the other key areas to look into is your operating physicians. If you have a wide range of physicians, it's helpful to see their post-acute utilization patterns, how they're discharging patients, and see if there's any specific areas there or physicians that you may need to have kind of discussions with. Reducing, or shifting post-acute care patterns can achieve significant savings. So in the example we're showing here, high IRF utilization can cause, you to be accruing losses, whereas low to no IRF utilization can achieve savings. So there's a lot of different facets of the data that you have available right now that can help you plan and make changes for the performance year.
Okay. Alyssa, that was useful. And I know some folks are asking questions. We are going to address questions at the end here. I think this brings us back to our final polling question. So as you think about your team implementation and your site, what area is your biggest barrier to success under team? So we have a couple of different answer options here, and I see Garrett is pushing that poll live.
Yeah, so as before, you should see this on your screen. And the question is, again, which area is your biggest barrier to success under team? Is it data availability and analytics, quality performance improvement, post-acute care performance improvement, or cross-organizational collaboration? And we're going to give it another 10, 15 seconds for folks to answer. And if you're joining us later, these are anonymous, and so feel free to participate, and we're going to share the results here shortly. Okay, and if there's something, by the way, that we didn't mention on here, go ahead and drop that in the chat. I'd be curious to hear if there's other barriers that we haven't thought about. All right, I think most of the results have come in. I'm going to go ahead and shut it down in 5, 4, 3, 2, and 1.
Excellent.
Okay,
Thank
Pamela.
you. Yeah, so what I'm seeing is that, exactly, in fact, 34% of you indicated that data availability and analytics is your biggest barrier, and the same percentage indicated post-acute care performance improvement. We have 25% of you suggested cross-organizational collaboration is the biggest barrier, and 7% said quality performance improvement. So that's definitely an interesting mix, right? I think a lot of people are we've split the vote. People have different priorities and different barriers. All of these are obviously quite important. And so, in the last part of this webinar, we'll talk a little bit more about action planning, right? How to move your organization forward and prepare for what's next and sort of address some of those barriers. So I'll go ahead and move back to the slides. There's many ways that you could establish an action plan. We're making a suggestion here, right? Here's how you could think about this if you're just starting to focus here. So in the first 90 days of the program, you have 68 or so left in that first 90 days. Establish a clear understanding of your baseline episode performance. So some of those questions that Alyssa was asking and answering, it's important to get that understanding. You want to look at volumes, you want to look at projected savings and losses, and identify cost drivers and variation, which might be related to post-acute care facilities or operating physicians, as Alyssa indicated. I think that we would see this as an important first step. I know a lot of you maybe did this before the performance period. Now that you have the most updated performance data from CMS, we would recommend doing it again, because what this will do is help you understand how much you want to prioritize each of these areas. Over the first and second years of the program, understanding you might only be carrying downside risk for the second year, or you might have sort of lower levels of risk depending on your track. You should work on optimizing post-acute utilization. And as you think about what the key problems are for you, it might involve a different intervention. So for some of you, there's some discharge management, whether that's targeted at specific service lines or specific operating positions, or it's more broadly across your organization. It might also involve physician incentives, right? Are you going to engage in any of the gain sharing that you could as a part of this program? And how are you going to hold physicians accountable for their behavior? Additionally, we'd recommend a focus on care coordination with primary care, with post-acute providers, and with ACO partners, because that can accelerate your progress here, sort of thinking more holistically, not just about this particular set of patients. And that leads to sort of the third step in the longer term, thinking about how you're going to use team data and the insights you've gained to inform your broader accountable care strategy at your organization. This can help you prepare for the next generation of CMS models. For those of you who might be looking at this feeling like a bit overwhelmed, this feels like a lot to do, there's a framework here that I'm showing that we often use to evaluate readiness for a model and identify gaps. So sometimes you might use this, we've used this with clients who are sort of thinking about a voluntary model and whether I should sign up. That's not exactly what we're doing here, right? More we're thinking about, CMS said I have to do this. What are the areas that I'm really behind the curve on? So first, financial, right? Do you understand the financial structure? And do you have a sense of how much you want to invest to actually lead to model success? So that follows from those questions Alyssa was highlighting. What are the maximal savings and losses that you could really expect in this program? Realistically, we understand you can't do everything. And so how much effort you expend on this program and how much it could pay off is an important question to ask. What's the potential ROI here? The second area is clinical. So broad success in this model and types of models like this requires clinical buy-in, because if clinicians won't change their care patterns, you're probably going to have trouble driving any broad success financially under the model. So do you have clinicians who can help with that? Do you have physician champions or service line leaders who are really motivated to make change? And how will you use any tools the model offers, such as waivers, for example, to help you drive that change? The third area is operational. So actually executing on your plans requires people, it requires processes, and it requires technology. So when you think about how this model will work, if you have goals that are related to, how are you going to track those primary care referrals? How are you going to document the reasons that patients might have gone to a higher acuity post-acute site than their peers? And how are you going to hold physicians accountable for that? It's important to make sure that what you're setting up isn't a one-time activity. We're not sort of saying, here's what we're going to change. Okay, everybody, change it. We're going to think over time about what we've implemented, measure whether it's been implemented, and measure whether it works in an ongoing way. And then the last column here is sort of relationships. How broad is your network, right? Both of physicians, of post-acute providers. Do you really have everyone aligned? Because getting everyone swimming in one direction is a big part of the battle to succeed in models like this. So in terms of next steps, right, this model is happening, right? It's happening now. And if you're participating, we would encourage you to look at your data, right? Analyze historical research data as well as your own CMS provided data, the baseline data that you now have, to inform preparation for participation. And that might be based on the volume, historical utilization, potential savings opportunity. As Alyssa showed, sort of we would see comparing yourself to various benchmarks as an important part of this to help inform how much you can realistically save. You might have another way that you're doing that, but I think doing that activity is important to help everyone understand where you're starting from and where you're going. Working with internal stakeholders to better understand the implications of the program is an important next step, right? So many of you I've talked to sort of what are the service line modifications that you're making now? How are you documenting things? How are you tracking patients? Some of it is it seems quite, minute, right? How am I making sure these patients get their notification letters? Those things are required of this model. And so your ability to demonstrate that you have made those efforts may be quite important here. And finally, make a plan for ongoing data tracking and support so that your progress is actually measurable and documentable, and you can use that as you manage your relationships with all of these stakeholders. If you're setting a goal and communicating that goal, you need to help people understand if they're moving towards that goal or not, and if they're not, what they could do about it. So team is here, whether we're ready or not. I know some of you felt very ready, some of you didn't feel ready at all. I think we would certainly recommend scheduling a performance review with our Milliman MedInsight experts to cover these clinical, financial, operational, and sort of relationship-based opportunities and challenges, and learn more about how our data analytic tools can help facilitate your success. So team is mandatory, but it's also potentially a bridge to a value-based future and to success in other programs as well, right? Thinking about the learnings. So we would certainly recommend that you prepare now. It has started, so we're here to think about maximizing your success. So with that, I think we're going to move to the question and answer session.
All right, yes. Great presentation, guys. And there's obviously a lot here. I know there's a lot of questions. We have a big audience. So if we don't get to your question, don't worry. Someone will make sure to reach out via email to get your question answered. But if you have one, go ahead and drop it in now to your module, attendee module there. There's a place specifically for questions. So with no particular order here, let's go ahead and get started. The first question is this. Is it true that quality measures will have a substantial impact on my team performance? And how should I think about quality measurement, and how are you taking it into account in your tools?
Yeah, absolutely. It's a great question. So CMS has a pretty complicated set of quality measures that they are assessing you based on, right? So they are focused on quality. They have set metrics for multiple years of the program that are different, and they probably reserve the right to change those in the future as well, right? We know that this model will change in future years. In general, I think that the quality component of the program is quite impactful to your financial results. It can swing your results by a large percentage, right, in terms of whether you have savings or losses. In our estimation, you know, I'm trying to digest this for you and sort of make it relatively simple. And so when we think about savings and estimating savings, you might have implied that that meant there's a point estimate of savings. I think savings estimation is really a range, right? As you think about your ability to look at what your performance would be if your quality is very high and what it is if it's very low. But in terms of what you should be doing, I think it follows along the same message we've been stating with the finances, right? Which is to say, look at the metrics and try and figure out where you are now so that you can assess how much to invest in improving those metrics. And improving those metrics in many cases will require hospital-wide intervention beyond just these patients.
Great. All right, next question is, are the post-acute provider comparisons risk adjusted?
Do you want to address that, Alyssa, in terms of how post-acute providers are compared to benchmarks, sort of at what level?
Yeah, so post-acute providers are, in terms of utilization and average length of stay, they are somewhat risk adjusted based off of the DRG. So we are including that. However, additional risk adjustment is not currently included. But for example, the outpatient lower extremity joint replacements and spinal fusion codes are grouped in with their corresponding DRGs because that is how the target prices are created. So CMS is viewing those as kind of a one-to-one comparison. And so we are aligning our benchmarks to that specification. We have also run the benchmarks through the rest of the episode specifications laid out by CMS. So they are, you know, team simulated episodes, but they don't have any kind of HCC level risk adjustment. It's purely kind of DRG based.
Okay. Next question is, how does medication management, particularly at discharge and post-acute transitions, fit into team's accountability framework, and what role do you see pharmacy playing in achieving better episode outcomes?
Sure. That's a pretty broad question. I guess what I would say is CMS is really trying to push as much accountability as possible to the team participants, right? And so, as I mentioned near the beginning of the call, the financial risk that the hospital is taking on, not of their choosing, right, includes almost all spending, like the majority of spending in that 29-day post-acute period. And so to the extent that patients have conditions that require medication to manage, that if they don't sort of get the right medication, that could lead to exacerbations. The hospital is going to be financially accountable for that, and that could include things that are related to the team condition, right? But it could also include things that you might think are unrelated, right? Like if a patient has an exacerbation of an ongoing chronic condition, if that chronic condition is something that could have been exacerbated by their team episode or that acute event, it's likely included in the financial accountability. And so I do think there is a role here for making sure that patients are essentially staying healthy as much as possible after their discharge for that period of the episode and hopefully beyond, right? The financial accountability ends in 29 days, but the patient remains sort of hopefully to a person worthy of receiving the highest quality of care. So I think there is potentially a role there.
Okay, great, thank you. Next question is this. To what extent do you see participants seeking to replicate this payment model with other payers to scale the gains from investing in achieving success in the model? And if you are seeing this, can you describe which parts of the model are being used in other contracts?
Sure, another broad question. Okay, so I think that, I'll go back here and say I started working on episode-based models at CMS in 2011. And CMS had done some small demonstration models before that, but that was really when they invested in larger scale episode-based models. I think since those initial models, I have often thought to myself, are people really going to keep doing this? And they do. They keep doing it, right? So I think we are seeing episode-based models across payers. In terms of team specifically, I mean, I would argue like team is kind of new in this space. And so it is focused on post-acute care utilization. I think this is a common issue with episode-based models and people who want to scale them, is that there really isn't as much waste, right? There really isn't as much unnecessary or variable post-acute care utilization outside of Medicare fee-for-service because other payers are already doing utilization management. So there's not like so many commercial patients who have a knee replacement who receive unnecessary nursing home care. It's just already something that isn't really happening at a level to drive savings. And so I think that this is it's a sort of broad answer. I think what we see is that other payers are interested in episodes and they are developing episode definitions that are relevant to their populations, right? So you see Medicaid episodes focused on maternity, you see commercial payer episodes focused on maybe things like colonoscopy. There are definitely some orthopedics in there. However, I think that the savings opportunities are fundamentally different for most other lines of business, right? In terms of how you optimize an episode, it's not as much just about post-acute care management. So I think the structure can be similar, and we do see a lot of retrospective, a lot of the trending, right? A lot of interest in regional benchmarking, but the savings opportunities for providers might be a bit different.
Okay. Next question, we have time for just a couple more. For what entities is Teams mandatory?
Do you want to take that, Alyssa?
Sure, I can take that. Team is mandatory for acute inpatient hospitals that are paid under the IPPS and the OPPS because there are both inpatient and outpatient episodes that are located in a geographic CBSA that was selected for participation. So if you have reclassified your CVSA for wage reasons, it is based on the address of your physical hospital location. And all of the reconciliation and financial calculations are done at the CCN level. So the episodes and performance on all of the episodes will be rolled up to the anchor CCN level. So the service lines could offset if you are doing well in one episode type and not so well in another one. They could offset, and you could be, net positive at the anchor CCN level.
Okay. Next question, moving right along, is can you clarify how the quality score factors into payment? Is it used as a multiplier across the board, or do you have to reach a specific threshold before any incentives are unlocked?
I can also take that one. There is no threshold to achieve savings. CMS is going to calculate a kind of percentage out of 100%, and they will apply that to your reconciliation payment or repayment amount to the extent that the quality score impacts. So it is a 10% CQS adjustment for upside in track 1 and track 2 and track 3. Downside, it's also a 10% CQS adjustment up to 10% for track 3. And then for track 2 negative, it's up to 15%. So at the outset, the quality score will never increase your reconciliation payment, and it will never cause you to pay more in losses, but it can decrease your reconciliation payments. So if you achieved 0 quality score, you would be getting 90% of your reconciliation payment, and it can decrease your losses if you achieve high quality. So it's a little confusing.
Okay.
But.
Yeah. Well, there's a lot here. So last question that if possible here, if we can do a semi-quick answer, if that's at all possible, is this. Is it possible that team can also improve my performance in the Medicare ACO I'm a part of?
Yes, is the quick answer, right? So when we think about the savings opportunities, we describe things like post-acute care management or working with operating physicians who are generally specialists to decrease variation in their performance. That can have immediate trickle-down effects to your ACO. Some of the patients might actually be the same patients, so you could be achieving savings in both programs. But even if they aren't, if you're creating incentives for providers to change their behavior, change their discharge patterns, or setting up high-performing post-acute networks, that could drive savings in both programs, in team, but also in your Medicare ACO that you're operating.
Interesting. Good to know. Well, that is all the time we have. Unfortunately, I know we've got a bunch of questions that came in that we didn't get to. Again, don't worry. Someone will make sure to reach out and get those questions answered. So keep bringing them, even if you have some as we're wrapping up here. Pamela, Alyssa, thank you so much for a fantastic presentation. I really appreciate you breaking this down for us. I know I learned a lot and hope you all did as well. As we close out, I wanted to encourage you all to head over to bbcexhibithall.com. And here you can check out the Milliman MedInsight virtual exhibit booth, where you can read up on them and what they're doing and take a deeper dive into some of their solutions and what they're able to provide. And also, of course, reach out to them through there. And there's also at the library at bbcexhibithall.com is where this webinar is going to be archived along with all the other webinars that we've done with Milliman MedInsight and others. So feel free to head over there. And then finally, if you would like to reach out directly to the Milliman team here, Pamela and Alyssa's emails are on this last slide here. So feel free to reach out to them directly, or I'm happy to facilitate an introduction as well if that's easier. So you can just send me an email or reach out. So thank you again so much for spending your afternoon with us. Pamela, Alyssa, again, a big thank you to you both. And we'll see you on the next one. Bye-bye, everybody.